button pushed. It should pop up in a sec.
Okay. Good morning, everyone, and welcome to PCEP for January 2023. We're going to do a focused review of CPR science and cardiac arrest, and then Dr. Whitwer has some additional teaching at the end. So I'm going to begin by reviewing the changes in ACLS that came out in 2022. The major changes are obviously around the reducing of provider risk. So especially wearing appropriate PPE, especially during aerosol generating procedures, making sure that you stay up to date with your vaccination and boosters, and then doing what you can to reduce provider exposure. So having appropriate PPE for aerosol generating procedures, so N95 or a respirator for any aerosol generating procedures, and then obviously gloves, gown, and critically eye protection, because we know a lot of transmission of respiratory viruses is through the eyes as well. What are aerosol generating procedures? CPR, defibrillation, bag valve mask, intubation, and positive pressure ventilation. Of those, intubation is probably the most aerosol generating. So there are recommendations to limit the number of providers and to use mechanical CPR when we're able, and to use HEPA filters in our ventilation system, and then using the intubator with the highest chance of first pass success in these critically ill patients. So we're going to review Crew CPR, the model for how we perform, how we give high performance CPR. So what are the principles? The EMT zone CPR, that we minimize the interruptions in CPR at all times, that we have proper depth of compressions, so at least 2 inches, that we ensure full chest recoil, that we ensure the proper chest compression rate with an ideal of 110, that when we're doing manual CPR, we rotate compressors every 2 minutes, and that we hover hands over the chest during shock administration to be ready to compress as soon as the patient is cleared. We use the iGel Airway with ongoing CPR, place any IV or IO while CPR is ongoing, and then we coordinate between the EMTs and the paramedics. So with high performance CPR, establish unresponsiveness, begin CPR. Why is high performance CPR so important? It's the foundation of the resuscitation. It is the single most important intervention when we're resuscitating someone from cardiac arrest. And it improves the effectiveness of all of the other treatments that we do. It makes defibrillation more effective. It makes medication more effective. Better compressions lead to better organ perfusion, which leads to better resuscitation. Appropriate depth of compressions increases the likelihood of a successful shock. When we compress, we're perfusing the organs. When we decompress, we're perfusing the heart. The pauses make a difference. So the longer the pause in chest compressions, the lower the chance of a positive outcome. So that is, having a perishock pause greater than 10 seconds is associated with a significant decrease in the effectiveness of the resuscitation. What happens if we don't have adequate recoiler compression? Sorry, I'm going to take. It's like someone else took over the screen for a second. I'm going to see if I can take that back. Okay, I'll go back to where we were. So if we don't decompress adequately, we won't get adequate blood volume into the heart and the lungs. And and that can have lingering effects on the coronary and cerebral perfusion pressures, even after we correct that deficiency. How does CPR affect medication? So the perfusion circulates the medication, better perfusion, better circulation of the medication. Good CPR decreases the amount of time required for epinephrine to reach peak concentrations when compared to poor CPR. So better CPR, better effect of the medications. So how do we carry out the teamwork? As everyone's familiar, it's the pit crew approach, which is dependent on regular rehearsal and practice, and everyone having this same goal in mind: high quality CPR, minimal interruptions, no longer than 10 seconds. It may need to be adapted when there are fewer resources available. Obviously, we have to move to an area where it is possible to continue the resuscitation. If you're limited in the number of rescuers, CPR and defibrillation take the first priority, and then we use the incident command principles as we build up our team. So first arriving paramedic will be the team leader. The first arriving company officer will be the fast attack incident commander, responsible for the non-medical management of the scene. And then the second arriving company officer will be the strategic incident commander, non-medical management of the scene, remaining in a strategic position whenever possible, not involved in the resuscitation. So position 1 on compressions determines cardiac arrest, exposes the chest, begins compression, announces when compressions are at 180, 190, and at 200. Position 2 on the life pack will turn on the life pack to stamp the beginning of CPR, start the metronome, and apply the defibrillation patches. AP placement is preferred if possible. Remember that if you have a refractory VFib, then it's time to change the placement of the patches. Monitor the compression quality, the speed, and the time intervals. Charge the monitor at compression 190 and interpret the rhythm and shock if indicated after compression 200. Alternate doing compressions if needed until additional resources arrive. Position 3 is airway. So we could begin with oxygen, 10 liters per minute, and then after the first ventilation can go to bag valve mask ventilation. Whenever possible, especially if you're with a limited number of rescuers, the IGL is really helpful because you don't have to put all the effort into making the mask seal, provide ventilations on the upstroke, attach end-tidal CO2, and do suctioning as needed. Intubation only if required for airway control and cannot interfere with compressions. Position 4 is an alternate compressor. Position 5, IV, IO, and medications. So IV to keep open with IV fluid above the diaphragm preferred. So we prefer antecubital arm vein, humeral IO, except in pediatrics, and then tibial or femoral IO in pediatric patients. If you don't have a promising first IV site, okay to go straight to IO, and this rescuer will administer any required medications. Position 6 is the strategic incident commander, responsible for safety, coordinating with family and other agencies, and developing the egress plan. Position 7 or 8 are backup to be assigned as needed. So as a reminder, here are the positions. Position 1 is the compressor. Position 2 on the life back. Position 3 on the airway. Position 4 is the backup compressor, and then position 5 for medications. So after the incident, company officers should debrief crews and determine where improvements can be made. And all personnel should review the CPR process file to look for opportunities for improvement in CPR. So just to review the 10 principles, EMTs own the CPR. We minimize interruptions in CPR at all times, proper depth of compressions, full chest recoil, proper rate, rotate compressors every 2 minutes, hover hands over the chest during shock administration, ready to compress as soon as the patient is cleared, iGel with ongoing CPR, IV or IO with ongoing CPR, and coordinate the teamwork between the EMTs and the paramedics. So okay, we know this, we work on this. What's the outcome? How have we done with this? So we now have full data through 2021. Roughly in April, we'll get data from the final data from 2022. So we use the Washington CARES registry. So here's a summary of where we stand with all cardiac arrests. So the orange is patients with sustained return of spontaneous circulation, yellow survive to admit, and then the orange are survive to discharge. And so this has been relatively constant over the last few years. We obviously saw the decrease in 2020, most likely related to the pandemic. And then we're close to where we are. And these numbers compare favorably with both with the state of Washington and with the national data. This is the foundation of our reputation as a high-performing system. And when we look at the Utstein survival, so these are patients with shockable rhythms. And here it's divided by all Utstein, all shockable rhythms, and then shockable rhythms that received bystander CPR. And so obviously there can be big jumps in these numbers because they're relatively small. But I do think it's relevant that we are showing a continued increase in our performance. And these are the patients that are most amenable to what we do as an EMS system. These are the patients that really reflect the teamwork, the CPR, all of the things that went before. And so it means if in Clark County, if all patients who have a shockable rhythm, 55% walk out of the hospital alive in 2021. If they get bystander CPR, 61%. And what does that mean? That means there are 18 people that are walking around alive just from 2021 because of the work you do. And so I think that's a tremendous accomplishment. And it's one that I'm just very proud to count you as my colleagues in this. Peace Health benchmarks against state and national guidelines in terms of what happens in the patients that come in, and it is in line with state and national outcomes in terms of who dies in the ED, who's admitted to the hospital, who's discharged alive. So what I would say, I mean, the big difference that we see, you know, when we say our numbers are better than Washington state numbers, better than national numbers, that big difference is directly as a result of what you do. And so that's all I have. Welcome any questions, but mostly I'm just grateful for the work you do because this is a tremendous accomplishment.
Perfect. Thank you, Dr. Mocht. Dr. Whitwer, do you want to try and pull up your screen, hit the share button?
Let me see if I can pull it up. It says I have to give them permission to share the screen. Oh, Jesus. Okay, hold on.
Can everybody see my screen?
Yeah, I'm gonna have to use your screen because I've got everything is on. I can't get the PowerPoint, that correct PowerPoint up. It's giving me all the other stuff, and I've got the PowerPoint open on my desktop. So, okay, I'll just go for this. I can manage that. That's easy enough. Are you hearing me okay?
Yes, we are.
Okay, good. Make it big enough so, all right. We have some protocol revisions to start, and the initial portion of this is protocol revisions that are intended to be instituted no earlier than March 1st. So this is a learning time, and so we're going to talk about the new national guideline for field triage of injured patients, which was the papers and acceptance were published in 2021. This is through the American College of Surgeons, and this will become the new national standard for field triage. Now, why are we doing another field triage things after you've spent a lot of time learning this one? Well, it's because you have spent a lot of time learning it. The first field triage guide was done in 1976, and I don't think anybody in the field was in. Many of you were not even born then, but that's a long time ago. I remember the first one, and the field triage guideline was very simplified in those days, and it was intended to be updated every 6 to 8 years, which it was, but the last time it's been updated was in 2011, because we've obviously 6 years after 2011 would be starting to approach COVID, and COVID happened. Now, why do we even have this triage tool? Well, it's been proven over and over again that the triage of suspected critically ill patients to the hospital saves lives and saves disability. There's no argument about that. That's been well established. Now, triage in any system that you're using, triage comes in two flavors. You have under triage, which basically means that that patients who should have been taken to a trauma center are not taken to a trauma center. They're under triage. Or you have over triage, which means that persons who really don't have a significant injury end up being taken to a trauma center because of the over triage. Now, the goals, interesting enough, the goals for under triage is 5% or less. That way you don't miss, if you have a high level of under triage, you miss patients who really could benefit from a trauma center. And over triage, the goal is 35% or less. And in other words, the system is willing to tolerate a large amount of over triage so that you don't miss so you don't have a lot of under triage. Now, the actual rates of under triage in the United States vary across states. Under triage varies between 14 and 34%, which means that a tremendous number of patients aren't getting to the correct trauma centers. Over triage nationally varies between 12% and 31%. Children are under triaged as much as 51%, and older adults are even more at risk for under triage. The new system, which was devised, is very heavily dependent upon statistics and information. Now, in this area, we actually contributed to some of this the number of papers that the county has contributed patients to through the ROC studies and some of the other related studies have come up with some good statistical evidence for how we should do triage. This was set up quite interesting enough by a national panel. They set up a steering committee, which met for about 2 years prior to 2020, doing some design. They had then a 2-day meeting in 2020, which they drafted proposed revisions, and then reviewed the draft, got consensus on it, sent the draft to stakeholders. The stakeholders were national organizations like NEMSP, National Association of Emergency Physicians, EMS physicians, to NASEMSO, which is the state EMS directors, to ACEP, to the College of Surgeons, to the orthopedists, to the neurosurgeons. That's all down the line, and most importantly, this time, to EMS organizations. They sent the draft to stakeholders, then got the results, they got suggestions and queries back, and then they updated the guidelines, redrafted, resubmitted it, and they had an end user tool which described this new process and sent it to 29 national organizations. Altogether, they got about 4,000 EMS clinician responses, which were integrated in the guidelines, and as you see as we go through it, what made quite a bit of difference. Now, why are we doing this now? Well, because the state has, in their wisdom, said, well, yes, we think we like this, but we're going to take our own time to decide when to do this. The trauma surgeons at Peace Health are anxious to get the new system in place because they believe that it will improve not only the triage, but will improve the ability for them to manage the care of patients. ESO is putting the new criteria and the new trauma tool into the EMR, so that should be available within the next month or so. And so Clark County, I've agreed that Clark County will trial this. We've talked to the state and said we're going to trial this out, and this is fine with them. So just as a refresher, here's the old system, which essentially had physiologic and anatomic activation criteria, broken up into 2 sections, which were referred to as box 1 and box 2, or box A and B, which were vital signs and level of consciousness and anatomy of injury. Then they had other activation criteria, which were the mechanism of injury types of things, and medication types of things, and some excuse me, some paramedic judgment, and some age related things. This has changed now. So we'll go on to the new system. Now, the new system is broken down into, now, remember the old system, the type part 1 and part 2 entries were full trauma activations. Part 3 and 4, the softer signs, would give you a modified trauma entry. Either one is a trauma alert act or a trauma activation. Now, they've changed this, and I'll get into more detail in a bit. They've changed this now to, instead of full trauma, they'll call it red criteria, high risk for serious injury, red criteria. And actually the red will be an option in the Pulsera, and it will also be an option for you to if you're on the HERE system, say I'm bringing in a red trauma, which would be a trauma activation. Now you could say trauma activation red, that'd be fine. Now, you notice that they've changed things a little bit. The first thing is injury patterns, and the next thing is mental status and vital signs. Now, I'm going to go at great depth, but the way this new system is set up, based on input from EMS, is that we go from you go from left to right in both the red and soon to be spoken about the yellow criteria. You go left to right based on the flow of information to EMS. You see the injury patterns on the patient first before you generally get vital signs, mental status, etc. So, and then the flow from top to bottom is the high versus moderate risk. So the risk decreases as you go down the line, the risk of serious injury. Also, the flow goes head to toe. So that's how you do your rapid exam anyway. Now, so next one. Here's the yellow criteria, and you have mechanism of injury and now EMS judgment. And once again, left to right, and then high risk to lower risk as you go down. But patients meeting any red or yellow criteria still go to Peace Health Southwest, because these are both trauma entry categories. Let's go to the next slide. Drilling down on this. Injury patterns. First thing you see. How has this changed? And there's been a couple of additional things. Penetrating injuries to head, neck, torso, and proximal extremities. The previous version said proximal to elbow or knee. Well, so they made it simple on EMS requests. Please just make it simple. Skull deformity, suspected skull fracture. That has just been slightly altered because you don't know that there's a skull fracture there. You suspect it. Also with spinal injury, suspected spinal injury with new motor or sensory loss. Used to be paralysis. Chest wall instability, deformity, or suspected flail chest. Once again, you can't prove the flail chest. Suspected pelvic fracture. Suspected fracture of 2 or more proximal long bones. Crushed, degloved, mangled, or pulsated extremity, that's no change. Amputation, proximal to wrist or ankle, that's really no change. And here's the new one. Active bleeding requiring a tourniquet, and we're going to say a tourniquet applied by EMS or an appropriate tourniquet. Well, we'll just say EMS for the time being, or wound packing with continuous pressure, because some wounds, as you know, don't have the ability. You can't put a tourniquet, in the groin, for example. Now, this is the most change of all. Mental status and vital change. All patients now simplified the GCS requirement to be a trauma entry. Unable to follow commands, motor GCS less than 6. Why did they change this? Many studies shows that there is no statistical difference between the outcomes and the identification of an injured patient comparing a full GCS scale, which is complicated, as you know, and a motor GCS scale of less than 6. If they're unable to follow commands, now there's a caveat here. If they're unable to follow commands because they don't speak English and you don't speak their language, you'll have to fudge that one, but that's relatively uncommon. Respiratory rate less than 10 or greater than 29 breaths per minute. That hasn't changed. Here's a new one. Respiratory distress or need for respiratory support. And respiratory support is defined as having, excuse me, as assisted ventilation, intubation, or mechanical ventilation. So anytime you need to assist their respirations, that'll buy you a trauma entry in a trauma patient. Room air pulse oximetry less than 90. Studies have shown that that is a clear indicator of a seriously injured person. Now, blood pressure. Blood pressure is an interesting thing. For 0 to 9, so pediatric, true pediatrics here, systolic blood pressure less than 70 millimeters mercury plus 2 times the age in years. So if you got a 5-year-old, 2 times 5 is 10 plus 70. Anytime, if you have a systolic blood pressure less than 80, that would be criteria for shock at that age group, and you would put that person into the into a trauma entry. Age 10 to 64 years of age, systolic blood pressure less than 90, that's not changed, but, or you can have an or heart rate greater than systolic blood pressure. This basically is taking into account what is called the shock index, which is exactly that. It's a heart rate greater than the systolic blood pressure, and anything over 1. So if you have a heart rate of 110 and a blood pressure of 100, the shock index would be 1.1, so that would be a positive shock index. So we're not asking you to calculate shock index, just if their heart rate's greater than the systolic blood pressure, that is a sign of probably a sign of shock, and you need to declare, if it's a trauma patient, you need to declare them as a trauma entry, and these will be in the red category. Age greater than 65 years of age, you have still this heart rate greater than systolic blood pressure, but this hasn't changed. It's actually in there now. It's suspected that if you're older 65 and your systolic blood pressure is less than 110 millimeters, it said you might suspect this as a sign of shock. We're saying yes, it is. So systolic blood pressure less than 110 in an elderly person, that buys them a trauma entry red on the basis of shock. Mechanism of injuries. A couple of things that haven't changed and just been altered a little slightly. Several high risk auto crash, partial or complete ejection. That's not a new one. That's in there. Significant intrusion. Now, this is interesting because I remember several of you have complained to me that some of the new trauma surgeons, at least a couple, 3 years ago, were saying, "Oh, the cars nowadays, you don't need to worry if there's intrusion because the cars are so good. There's no problem." Well, that's not true. So the statistics show greater than 12 inches in the occupant side, or greater than 18 inch in any site, or now here's the new need for extrication for entrapped patient. So it used to be a time limited thing. It turns out that there is good correlation with severe injury down to less than 5 minutes of extrication time for an entrapped patient. So we don't look at the length of time now. If they're entrapped and you have to cut them out, if you have to use jaws of life or whatever to get them out of there, that's an entrapped patient. That buys them high mechanism of injury. That's a yellow injury, remember. Now, death in the passenger compartment, that's been there forever, and that still is statistically significant. Child 9 years of age or less who's unrestrained or in an unsecured child safety seat, and they had the wreck, a significant wreck. Vehicular telemetry data consistent with severe injury, that was touted as being a great thing, but there's not that much telemetry data available. New one, riders separated from the transport vehicle, and the transport vehicle can be described as a motorcycle, an ATV, or a horse. I don't know, a horse would like to, you could call your horse car, I guess. So this is a significant, usually it has to do both with the speed and with the fall, but they cannot find any correlation between speed, any good correlation between speed. Motorcycle used to say more than 20 miles an hour. That hasn't panned out. So just any separation if you're ejected from your motorcycle. Pedestrian or bicycle rider thrown, run over, or with significant impact. And now a moderate change, fall from height greater than 10 feet, all ages. Used to be 20 for an adult. That's now 10 for everybody. And EMS judgment. These are the things that used to be the number, the box 4. Low-level falls in young children less than 5 years of age or older adults greater than 65. This is considered risk factors. So if they have a, quote, significant head impact, that doesn't say you find a significant head injury. You find if they have a significant head impact, they fall from standing and they smack their head on the concrete. Anticoagulant use, we all know and love that, and that includes antiplatelet agents. I haven't got the decision from. I think we have taken aspirin out of the antiplatelet agent because it's not a significant one, but and we'll just monitor that one. Suspicion of child abuse. Any child abuse has a very high risk for significant injury. Special high resource healthcare needs. Now that doesn't mean special needs persons per se. That means high resource healthcare needs. For example, if your patient is ventilator dependent, they're going to need to go to a place where you can manage it. If the patient has an impeller-based heart, they need to go to a special hospital, which is best met by a trauma hospital. Pregnancy greater than 20 weeks, because you're dealing with complications and things of 2 people, basically. Burns in conjunction with trauma. Now, this is a choice of the if you have a significant injury that needs immediate care at a trauma center and a minor burn, then the regular trauma center would be the best place to go. But this is a judgment thing of where that patient goes. And then the caveat, children should be triaged preferentially to pediatric capable centers. All level 2 and level 1 centers, even if they're not pediatric hospitals, have committed to having resources for urgent care of pediatric patients, and then and then transfers can go. Now, if you're concerned about a patient at any point, take them to a trauma center, obviously. Now, EMS, so we have the reds and the yellows. Those are both trauma entries. We will have you be reporting to the hospital that you're bringing in a trauma patient. Red, and then the Pulsera will have a red identification, and then we'll be able to adjust that. You'll be able to put in the reasons that they were entered into the trauma system and the reasons that they became red. If same thing for yellow, and the hospital then will react to either the red or yellow in the way that the trauma system at that particular hospital is set up. But this is our PreHospital tool. Now, we're going to be refreshing this and going over this again and again and again over the next month and a half, with the planned rollout of March 1st. This is in conjunction with Peace Health Trauma Group. Now, just a reminder for diversion criteria in trauma. Major burns, if you don't need to stop to do, if there's something else in the trauma that needs to be dealt with at that point. Most of the time, our major burns are burns alone. Pregnancy with multi-system trauma in shock and unresponsive to aggressive resuscitation, or if you anticipate emergent immediate surgery. So that would be a divert to a level 1 trauma center. Or Peace Health Southwest advises diversion based on their information they get from you and their and if they've already taken 2 or 3 trauma patients, they will be diverting a significant trauma patient. And then pediatric trauma diversion. All pediatric patients less than 15 who are trauma entry, so either they meet the red or the yellow criteria, go to level 1 hospitals, either Emmanuel or OHSU, unless you need to divert for airway control, vascular access, or cardiac arrest. Okay. Next. All right. Now we're changing our notification of patient acuity. And I'll explain a little bit that the hospital has basically 2 modes of addressing patients. They either when you bring them in and call them, you've only been able to call them code 3 or code 1. Code 1 patients, they're assuming the code 1 patient is non-life threatening and probably could wait to be seen, and indeed gets triaged generally to the triage nurse and triage desk during especially during these busy times in all EDs. Patients who come in code 3, of course, then the nurses are making the assumption that these are high priority patients who need immediate attention, and often the and the nurse and the whole team is pulled out of whatever they're doing so they can greet the patient who is presumed critical. As we all know, a lot of these patients are not critical. I've done some review of the Code 3 returns, and I see as much as 2/3 of them are really not priority patients. They're not absolute critical patients. So we're going to switch your entire reporting system to the nurses, to the hospital through Pulsera and by here to the Acuity definitions, which pretty well match the trauma definitions that I just talked to you about, and we'll make and they also follow very much the START triage tool for mass casualty, where the Acuity definitions of a red patient are patients presenting with symptoms of life-threatening illness or injury with high probability of mortality if immediate intervention is not begun to prevent further airway, respiratory, hemodynamic, or neurologic instability. In other words, red equals priority patient. A yellow patient is patient presenting with symptoms of illness or injury that may progress in severity and may result in complications if treatment is not begun quickly. But these are the urgent patients then. These are not the ones, these are the ones that you would want them to be seen by a physician or a triage, an EMS nurse immediately, and you'd want to tell them more about the case and about your concerns. But this is not a priority. This doesn't require a full court press of everybody running to see the patient at that moment. I'll give you an example of that. This would be well, then a green patient is a patient who's presenting with symptoms of illness and that has low probability of progression and can wait and be taken in as beds and things become available. Let's go to the next. So, Mark, there we go. So, here's an example of a red patient. Any symptom activation, trauma red, STEMI will be a red, stroke alert would be a red, sepsis alert would be a red, septic shock would be a red. Intubation, you've already intubated the patient, or you can't control their airway. Now, ordinarily, it'll probably be intubation. So any intubated patient will be red. Any cardiac arrest will be red. Hypotension, not responding to treatment. Uncontrolled hemorrhage, and that includes hemorrhage with an EMS applied tourniquet or wound packing. That's a red. Imminent or precipitous delivery. So, like I said, these are not limited. You can think of many others that fit that. Now, a yellow patient is any yellow trauma triage criteria. That's still trauma alert, but it's a yellow alert. It doesn't require the full court press. ACS without EKG changes and normal vitals. Up to now, many of you have been calling, you've got 1 or 2 or 3 normal looking or non-diagnostic 12 leads. The patient has had symptoms for X amount of time, sometimes on and off for days. It may be an NSTEMI. It definitely needs to be evaluated, but it doesn't need to come in as a quote priority. You need to see this patient right now. This needs to be seen urgently and the issues addressed but this is not a critical patient at that moment. So ACS without EKG changes and normal vitals. TIA with resolving symptoms. You can say, well, I think this is a TIA. That doesn't need to come, that needs to be seen, evaluated, and it may well be a stuttering stroke, but it needs to be evaluated by the doctor urgently, quickly. Should not go to triage. And hypotension responding to treatment still needs to be seen soon. Hemorrhage controlled with a tourniquet, but not applied by EMS. Laceration and wounds requiring surgical intervention. Potential surgical abdomen without hypotension. Those are examples. You can probably come up with dozens of others. The kind of things, many of the patients that you now are calling, because you don't have any other choice, you're calling it code 3 lights and sirens. They will fit into this category of a yellow. Then green is any transport not meeting any red or yellow acuity criteria. Now this gets us to transport mode. Transport mode is entirely up to the choice, up to the decision of the transport crew. Lights and sirens are used if the patient requires a time-sensitive treatment that's not available pre-hospital, and the transporting ambulance will be operated per RCW and local company policies and procedures for emergent operation of the vehicle, which means that you use that time of day, traffic, road conditions, etc., may determine how you operate that vehicle. For example, if you're coming at 3 a.m. from Camas, it's doubtful that lights and sirens down the highway will gain you any improvement in arrival. Now, if you're going at 5 o'clock in the afternoon, that may not be the case. So lights and sirens, as we all know, are dangerous for everybody, including the patients, the crews, and the public, and this is where accidents happen. So we're trying to not trying to eliminate lights and sirens, but to decrease it. It should gain you should gain some advantage for the patient to use lights and sirens. No lights and sirens. All other transport should be lights and sirens without use of emergency warning systems or traffic control devices and following all traffic laws. So the transport, everyone gets training. All of the transport people get training in making decisions in this, and so you can, we'll work through this. Now, some slight changes in COPS, in the non-transport of patients. Criteria for no transport. You can recommend no transport if no emergency medical need, and under routine operations, if the patient or decision makers request, usually under normal times, the patient's request for transport will be honored. However, you can leave the patient scene if you recommend transport and the patient has been informed of the risk of refusal and has signed a refusal form. That's standard referral or a refusal. As long as you recommended transport, but the patient refuses, they need a refusal form. The EMT and the patient or decision maker agree transport is not required. And in this case, they would still sign a refusal. If you agree transport is not required, you just have them sign the format which says you've given them the warnings, the informed consent kind of stuff, and then they sign a receipt that they got it. Obviously, if the patient is dead on arrival or resuscitation efforts have been terminated, you do not need to transport that patient. Now, the exception, if we declare crisis standards of care, go back one, please. If we've declared crisis standards of care like we have during the height of COVID, and just recently we've done a sort of modified crisis standards of care because of the overwhelming number of worried well with viral illnesses. If the EMT recommends no transport and the patient or the decision maker requests transport, then you contact medical control. Medical control and explain what you're finding. And if the EMT and physician agrees there's no medical benefit to transport, we will leave the patient at scene. Now, sometimes the patient will be expected to talk to the physician, and that's okay. Now, I mean, that's a good thing. Now, if they have
For a couple of minutes with this.
if they have I'm sorry, I was getting interrupted here. If in this case there's the form that you sign telling the patient how to, that advises them how to take care of their illness, when to call if they become more sick, and it will document all the vital signs, etc. And you will leave that with the patient, have them sign that form, and you can take a copy of that. I would just take a picture of that. Next. Now, patients refusing care. Non-emergent medical need exists. If transport's recommended the EMT, a refusal form and MIR must be completed by the EMT or paramedic attending the patient. If transport is not recommended by the EMT, complete the MR with all necessary elements, explain decision-making, give the callback precautions, this form that I'm talking about, and just have that signed by the patient. Leave that with them, gives them more instructions, take a picture of it, put it in your chart. MIR documentation includes all the necessary elements, and the disposition is patient treated and released per protocol. Now, once again, if we've declared crisis standards of care, refer to the non-transport crisis standards of care protocol we just talked about. Next. General housekeeping things in the, we didn't find many changes to do. Ketamine. We removed the IM dosing option. We're not using it, and it was confusing to people. Changed BSS verbiage to normal saline. Bicarbonate repeat dosing removed for hyper-K and ODs. The chances of you needing to repeat the dosing in anything except North Country is rare. Bicarb routine use in cardiac arrest was removed, but it's there for hyperkalemia suspected or tricyclic and Benadryl overdoses. Now, I'm aware, and I'm trying to chase it down. There is allegedly a published report showing actual improvement of survival in cardiac arrest with bicarb given. I have not seen the actual paper, so allegedly it's peer reviewed, but I haven't been able to find it yet. And so we'll think that, but we don't routinely use it. Now, I am never upset if you use bicarbonate in a suspected severe acidosis related to a respiratory based arrest, because that person will probably be quite acidotic. Fentanyl for pain every 5 to 10 minutes.
None caller.
Jesus. And for pediatrics, we have taken ketamine out of the pediatric protocol for pain. And it's not, according to Randall Trauma Group, it is not appropriate for pain control in pediatric trauma patients. So we're just taking it out for peds. It's there. We have the children do quite well with fentanyl, and it can be given intranasally, et cetera, et cetera. So I think that's the end of our general housekeeping. Does anybody have any question? I wasn't looking at the chat, so I'm just.
The only question in the chat is about Pulsara and red, yellow, green. My understanding is that's already built into Pulsara, but I want to defer to someone who's more familiar with that than me.
It is, and that will be, and actually, it comes up red, yellow, and green. So
to clarify that, you'll still put the criteria that the patient's being transported as, but there is an acuity section in the trauma module that is it just says green, yellow, red, and black. There's no predefined definitions for that. It's based on how we define what those are. So when you put in your criteria for activation, you'll put I believe it's under triage conditions, and then you'll indicate whether it's green through. We won't have a black, but it'll be green through red.
we won't be using black because, as you recall from the start thing, the black is dead. We don't transport dead persons according to Washington State RCW. Anybody have any others? A lot of stuff, but actually the trauma triage thing makes more sense, and it is statistically driven, and it should improve both our ability to get the patient categorized as a trauma patient, and also to get the trauma surgeons to respond with the correct amount of resources, etc. Like I say, this is, we're going to continue laying this out over the next month and a half with an anticipation of being go live on 1st of March, which I believe is a Wednesday. Of course, the major burden on this falls onto the transport persons, which I apologize for, but all agencies and all medics should understand what the triage criteria are now, because you're usually first on scene, especially at the far reaches of the county, and so you'll need to advise the arriving transport medics as to what's going on. And often you'll be riding in with the patient too. So, all right, well, that's all I have. We almost made it in an hour, but if nobody has any other questions or any concerns, have a great rest of the month, and encourage your fellows to see this, to view the taped version as soon as possible, so that we can all get this moving forward.
Just a quick little note for those of you who didn't see it in the chat. I think the quiz was, there was an accompanying QR code for the quiz for feedback. I don't think that link didn't work so good. There's a link in the chat. Please provide us some feedback. It's always helpful. And if there's not any more questions, we'll end for today. Thanks for coming.